back out at the last moment, so I think and none of you are ready to prepare a case which is an issue. I think कोई तैयार ही नहीं था, which I find surprising actually. I thought I would have people fighting for कि हम करेंगे, मगर आपने तो कुछ उल्टा सा होता है. Anyway, I thought I'll talk today about albuminuria. I don't know. So why do you think albuminuria is important? Identify yourself.
I'm from
Medanta. Doctor?
Darshit.
Darshit ji बताइए. Why do you think you joined this year? Last year. So why do you think albuminuria is important? Why should we be talking about albumin? For a nephrologist, what does it mean to you? What do you understand albuminuria?
It signifies the pathology in the glomerular basement membrane and will lead to fibrosis and tubular atrophy and fibrosis and worse prognosis if it continues.
It means worse prognosis in what sense? What's worse prognosis? I don't know. What is worse prognosis for what? What does worse prognosis mean? Anyone else? So it tells us about, it's a damage marker. It's a biomarker for kidney damage, isn't it? So it's a biomarker of kidney damage. It tells you about the damage in the kidney, whether it is in the glomerulus, low levels of proteinuria or albuminuria could be also features of albuminuria, usually a feature of glomerular disease, but there may be also features of, part of it may be also features of even a tubular interstitial disease or tubular disease. So it's a marker for, a biomarker of kidney damage, isn't it? But what does it in true sense identify? Why is it that it's important to us? It's a damage marker, but what does it tell us something more than what it is? Yes.
For progression of kidney.
So it is a marker for progression of kidney disease. So you said it, that's why it's important for us. So higher the amounts of albuminuria or proteinuria, higher the chances of progression. There is enough evidence in any disease that you take. If the amount of albuminuria or proteinuria is high, the prognosis of that person for progression of kidney disease is higher. So their progression will be much higher in comparison to those who have less protein. Nephrotic range proteinuria has worse prognosis in comparison to non-nephrotic proteinuria. So as a nephrologist, you get worried when you have nephrotic range proteinuria. You want this to get reduced to lower levels of proteinuria. So it identifies people who are at high risk of progressing to advanced kidney failure. Anything else?
It is associated with increased cardiovascular risk.
It is associated with increased cardiovascular mortality. So even smaller degrees of albuminuria are associated with higher cardiovascular mortality. And the commonest cause of death in patients with chronic kidney disease is cardiovascular mortality. So it is associated with cardiovascular mortality. Anything else? What else? ये तो फंडामेंटल है भाई. थर्ड ईयर स्टूडेंट्स तो हीट मैप. You've seen the CKD heat maps, ना? CKD heat maps में क्या क्या चीजें हैं? Cardiovascular mortality, progression of kidney disease, what else? जी भाई और ESRD, development of ESRD. So progression of kidney disease also signifies a similar kind of thing, but development of ESRD is an event, an event. Usually most of the studies that you look at will look at the end point of development of end stage kidney disease, isn't it? So that's what they would look for. So development of end-stage kidney disease. So people with higher degrees of proteinuria are at higher risk of development of end-stage kidney disease. And they are also at high risk of development of overall mortality, all-cause mortality. So proteinuria is extremely important, not only for the survival of that person. So he is at highest risk of development of all-cause mortality, whatever the cause of death. He is at high risk of developing cardiovascular mortality. He or she is at higher risk of development of end-stage kidney disease and progression of kidney disease. So that's why albuminuria or proteinuria is important to nephrologists, because it reflects, and it is an independent risk factor for all of these, independent of the serum creatinine or level of kidney function. Every stage of kidney disease, increasing proteinuria is associated with greater mortality, greater progression of kidney disease, greater. So if we are talking of 90 to 105 GFR, stage 1 kidney disease, isn't it? 90 to 100, but albuminuria A1, A2, A3. So A1 would be the reference point, but A2 and A3 are associated with increasing the same level of, so independent risk factor. And small decrease of normal albuminuria, then moderately increased albuminuria and severely increased albuminuria. Moderately increased albuminuria, say cardiovascular mortality is how much? In comparison to normal albuminuria, how much is the mortality? 2 times. And then severely increased albuminuria, 4 to 6 times higher mortality. So there is an exponential increase in smaller degrees of protein. This you should be knowing from the heat maps. So we can look at the heat maps, and they are here. So, should you call up? How do you measure it? Slide. Sure. Huh? Okay. Okay. So you can see that this is albumin creatinine ratios on the x-axis and hazard ratio for cardiovascular mortality. And when you have albuminuria up to 30 milligrams per 24 hours, is normal, isn't it? Up to 30, less than 30. But look at what happens. Even at 30, even within the normal range albuminuria, you have increasing mortality. So 5 milligrams of albuminuria is associated with a reference value of 1, but 10 milligrams, slightly higher mortality. And 30 milligrams, higher than that. 300 milligrams, you can see 2 to 3 times, then 4 times. So increasing albuminuria is an independent risk factor in its own. So let's look at those. So small increments in proteinuria increase mortality substantially. These are the heat maps. So this is all-cause mortality. You can see that GFRs, albumin creatinine ratios within less than 10 reference value 90 to 105, we can say. Albumin creatinine ratio within the normal range, 10 to 29, 1.4 times higher mortality. Albumin creatinine 1.5 to 2 times higher, and then 3 to 5 times higher mortality associated with this. So you have increasing mortality just because when the GFR is also normal, even then albuminuria carries it. Obviously, when you have decreasing GFR and an increasing albuminuria, you will have increasing risk of mortality. And you look at the dots here at the down, 6.6 times higher chances of mortality for all-cause mortality. Now, same is true for cardiovascular mortality, 4 times higher albuminuria independently associated with higher mortality. Same is with kidney failure. So you have development of end-stage kidney disease. So albuminuria, look at it. What are these numbers? 7.8. So what is it? This is? What is this? No. But what is it? What does it tell you? What is it for? This 7.8, 18, what is it? It's a relative risk. How do you find the absolute risk? How will you determine the absolute risk? Anyone? How do you determine the absolute risk from this? Incidence of. When you multiply it with incidence, you will get an absolute risk. Relative risk multiplied by incidence of that is equivalent to an absolute risk of this. You need to, this heat map is extremely important from the point of view of understanding and also from the point of view of day-to-day practice itself, because it tells you many things. So that's why KDIGO has developed these for you to understand as to that albuminuria and kidney function are independent risk factors for all these. Kidney failure is important to a nephrologist. All-cause mortality is important for a nephrologist. Cardiovascular mortality. If patient is not there, then there is no kidney failure or no kidney disease. So mortality is a hard endpoint of most of the trials, and these have been studied very effectively in multiple trials that you have. So this is why albuminuria is important. And you can see that progression of kidney disease as you talked about as well. So this is why I wanted these heat maps actually to tell you that albuminuria is an important thing for nephrologists to see. So how do you determine albuminuria? ये इनको भी मास्क ये दे दो ना माइक एक माइक अगर और है ना माइक हाँ अगर है तो काम कर रही है तो दे दो So you could no but how would patients know that they have albuminuria? Would be by a
urine routine.
So you do a urine routine analysis, and in the urine routine how do you measure albumin protein?
Urine dipstick.
So you could do a urine dipstick, and urine dipstick identifies what?
Albumin.
It identifies albumin. And so, before we go, what is the kind of difference between proteinuria and albuminuria? What does it tell us?
Few diseases will have selective protein loss, that is selective albuminuria. And proteinuria can be either.
So in normal urine, how much is the amount of proteinuria that we have?
Less than 150.
So 150 milligrams in 24 hours would be a normal proteinuria. In this proteinuria, how much is albumin?
Up to 30 will be.
So up to about 30 milligrams may be albumin. Usually around 10-15 milligrams would be albumin. What is the rest of this protein 150 milligram? So tam phosphol protein and beta 2 microgram. What else? Pardon? beta to microglobulin, she said. Anything else?
Vitamin D binding protein.
Yeah, there would be some other sort of globulins and all, low molecular weight proteins, usually, which are not absorbed by the protein or by metabolic from the protein, from the tubule. So you have about 150 milligrams of protein in these. Now, so albumin comes from where? Okay. So most of the protein that is found in the urine comes from where? No. Is some protein filtered? No, but albumin has a molecular weight of? What's the molecular weight of albumin? 68,000. So it's not permeable, ordinarily not permeable. Because the molecular size of kidney, the filter doesn't allow it, and then it's negatively charged also, so it's not. So usually you don't have it. So very small amounts of albumin will get filtered. So what's the most of the proteins which are filtered are? Lower molecular weight proteins which are below 68,000, something like 15,000, 20,000, 25,000. Those get filtered. And they are usually reabsorbed by the tubules. But so tubular proteinuria is what? Proteins which are filtered by the glomerulus, they are not reabsorbed or metabolized, is what tubular proteinuria, which is usually how much? Yeah, less than a gram. So usually 400, 500, 600 milligrams. So less than a gram of proteinuria would usually be called a tubular. Kind of small amounts of these are proteins which are filtered but low molecular weight, and that's why they are low molecular. Okay, so then you have what is overflow proteinuria?
The proteins are not reabsorbed, like in myeloma, the light chains are not too much to be reabsorbed.
Yeah, or the proteins which are normally not found in the urine, but in conditions like multiple myeloma, light chain disease and all, when these are manufactured or secreted and filtered in larger amounts, and then they will get excreted into the urine. It's called light chain or overflow proteinuria. So proteins which are in higher concentrations than they are not normally found, and then they will be filtered in there. They'll call overflow proteinuria. Okay. So what is orthostatic proteinuria and what is orthostatic proteinuria?
Some people on standing for a longer time,
It happens only in some people, or it happens in everybody? Yeah, so if you look at proteinuria in 24 hours time, usually you pass more protein while you are standing and active than when you are. And in some people who have slightly higher proteinuria, it may get aggravated to that extent, and therefore it's called orthostatic proteinuria. But this is a benign condition. This happens in many people. All of us probably also actively, when you exercise, there is exercise proteinuria. There is an orthostatic effect on proteinuria. And so this happens in most people who will have proteinuria. During daytime, they will have more protein than during the lying down period or resting period. So that's called orthostatic proteinuria. So now, how do we measure it? You said that you will measure it by a dipstick. Dipstick measures only albumin. So it doesn't measure other proteins. So what is the method where you will measure other forms of protein?
24 hours.
No. Any qualitative or semi-quantitative test, which you don't do these days. Sulfur salicylic acid. You don't do it by you add sulfur salicylic acid. Everyone should know about sulfur salicylic acid actually. And once in a while maybe. It is true that we usually are more these days doing dipsticks, and even in the labs, they do mostly dipsticks, and therefore they will not necessarily do a sulfosalicylic acid test. But sulfosalicylic acid, you should know as a nephrologist, is very important to you. For you to know that sulfosalicylic acid is the test by which you will measure proteinuria. It's a semi-quantitative kind of a thing. And anyone who can describe it, how do you report it? Yes? Anyone? No one. Anyone has seen it being done? These days not being done. Not in fashion. So you don't do it. Your एग्जाम में पूछेंगे, मैं बता रहा हूँ आप. तो जो थर्ड ईयर वाले हैं वो तो पढ़ लें एक बार सल्फोसलिक. ये एग्जाम में पूछा जाएगा, पक्का होगा कि जब भी प्रोटीन्यूरिया कहीं आएगा तो examiner will catch you on sulfosalicylic acid because they know that you don't do it, and therefore they will ask you this. At least to let you know that you don't know this question. तो इसलिए पढ़ लीजिए. So sulfosalicylic acid, so you use this for, you can heat it at the end, and the amount of protein precipitation which occurs on the tube is what you need. So you fill it with about 2/3 and then add 1/3 water, 1/3 of urine, and then you will put it on the heat at the end, and then you will see the precipitate coming in, and depending on the degree of precipitation, you label it as trace 1+, 2+, 3+, which is what many reports. Sometimes although albumin is also good, but when people look at protein, they may be doing sulfosalicylic acid, and so they report it as 1+, 2+, 3+, or 4+. So that's how this would be reported. So how do you quantify 24 hours protein? By 24 hours? Yes. So you will do what?
So to discard the first urine sample of the day and then overall till the next day first.
So how is 24? How will you tell a patient? Children tell me. How do you tell a patient? No, you consider me a patient, and I don't know how is 24 hours. So tell me, what will I do? Give me exact. How will you tell a patient to do a 24 hours urine collection?
So when you get up in the morning, so the first urine that you pass, you don't have to collect that, and the next time you pass urine, you have to collect that in a container, and the entire day you have to collect a urine in that container, total amount that you've passed, and the next day the first morning sample also has to go into the container, and then that has to be sent to the lab.
So I wake up on Monday at 5 o'clock. I pass the urine at 5 o'clock in the toilet, okay?
Yes.
And then I collect the next urine onwards, I collect it, okay? I don't know when I do the next collection. You don't tell me when should I do that, but whenever I pass. And next day I wake up at 10 o'clock. So next day I wake up at 10 o'clock. So now,
Yes,
what is the
first
So,
the
I started at 8 o'clock on the first day, and now I get up at 10 o'clock. It's already 2 hours late, so it is 26 hours.
So that
Anyone else can make it better?
Sir, we have to ask the patient to start. He can start any time during the day, but whenever he starts, we have to ask the patient to pass the urine, void the urine, and note down the time.
Yes, it is extremely important to tell him that it doesn't matter whether it's the first urine, second urine, third urine, fourth urine. You tell him that you start your collection whatever time. You can ask him what is more convenient time for you to start. It depends on somebody. Usually collections may be done. These are difficult to do because you have to carry the can otherwise with you. So you may do it much more conveniently on a Sunday when most people are probably off. But then there may be some person who may not be off on Sunday. So you might have to. So tell him or her that you fix up a time, say 7 o'clock in the morning. So it's important. Don't tell him first when you get up. You don't know what time people get up. So you give him a time. 8 o'clock, 7 o'clock, 2 o'clock in the afternoon, any time. That's not. But go to the toilet, clock it on the time, 8 o'clock. 8 o'clock you pass the urine out. You don't collect that urine. After that, whatever urine you collect, till next day 8 o'clock, you collect all the urine. And 8 o'clock next day, you again pass the urine. Even if you have passed the urine at 7:45, you go again at 8 o'clock. And pass that urine, and that urine has to be collected. So where are you starting the collection? What do you want him to pass the urine at whatever time he starts? And that urine is not collected. Why do you do that?
Sir, in the morning.
No, not in the morning. I'm saying, why would you want him to pass the urine and the first urine is not collected? Why is not that collected? I want to understand whether you understood the concept.
It's the entire 24 hours.
You are basically collecting urine where? Where does human beings collect their urine? In the bladder. So you want to empty the bladder. You want to know when is the bladder emptied. So that is the time when you start collection. So you want to know the time when the bladder is empty. And you are transferring this collection which is happening in the bladder into the container. So basically you want to know the time the bladder is empty. So you are basically wanting, because if you tell me that okay, you go and pass urine whatever time, I don't know, that urine may have been of 5 hours. It may have been the whole night's urine. Who knows? So you need to ensure that before you start collecting, bladder is empty. And bladder is empty, and then you do the collection. Okay? So that is the importance. And you end it with again emptying the bladder. So that all the urine at till 8 o'clock is already into the container. So you're basically collecting urine in the bladder, and you must know that when the bladder is empty and when the bladder is empty the next day. And that urine is the 24 hours urine. Okay? So it's very, very important because patients get confused. That's why 24 hours have been sort of not considered to be, although it's the gold standard, but they're difficult to do. You have to carry a container. So many patients will miss some urines in that. The other thing is that it's difficult to understand this for a patient. First urine, last urine, kaun sa wala, which wala. Or if nephrologist hasn't understood it and you're not able to convey it to him, then how are you going to be able to expect that he's going to do a correct urine? Okay? So 24 hours is an important thing in a nephrologist practice. And how you convey to patient, and you will have patients of all kinds with differing intelligence. So it's very, very important to tell them as to how you let this. Okay? So 24 hours urine is collected and you measure it. So can anyone tell me how do you measure albumin? What methods do you use? Anyone? Pardon?
Dye-based techniques, bromocresol, bromocresol,
Bromocresol. और कोई
sir, immunoturbidometry,
और
nephrometry,
or the best method you haven't told. Anyone? HPLC. That's the best method actually. The most reliable and reproducible method is HPLC. All others, nephrometry, immunoturbidometry, and precipitation methods, and all those are radioimmunoassay. They're all, but unfortunately, most of these have poor sensitivity, specificities, as well as reproducibility of these tests is unfortunately poor. So HPLC is a good method, but not practiced commonly, and that's a bane of the 24 hours urine albumin collection is that albumin is not measured, and many labs are not standardized for this. And so so many people, when you do microalbumin, when you ask people for albumin, they test it by microalbumin method actually. and then dilute the urine to get it into a specimen. So there is a complicated method of dilution and then measuring it, and therefore there are inaccuracies which are coming into it. You'll have patients coming into your OPD, sir, ये तो बढ़ गया, ये कम हो गया, ये हो गया, because they will not necessarily mean that they have gone up or down, but basically because these were not collected properly, they have been also not tested appropriately, and there is a variability in the test itself. So that's the problem sometimes in these, and you may make a decision based on these numbers and try to go up and down on treatment because you consider that proteinuria is an important biomarker and therefore you need to act, which is true. But you also need to take into consideration that what are the variations which can occur in these due to the lab variations, collection, and all other things that might intrude into the testing of these. So you do a 24 hours urine protein, you do a 24 hours urine albumin. So what's the difference between protein and albumin that you will do now? You did 24 hours protein, so what should you do? 24 hours protein or 24 hours urine albumin? So what would you do? 24 hours urine albumin. 24 hours urine albumin, urine protein or what? I told you that albumin is a bit difficult to do. In practice, you many times do 24 hours urine proteins. And most of the time, what is measured is basically in that albumin is protein. And measurement of protein probably less. I told you albumin itself is more difficult to measure unless it's done by an HPLC and all that. So most often we use it and predominantly by bromocresol and other methods. It provides you a measurement of protein. So more commonly when you see patients in the clinics, you do. And then even in glomerular diseases where actually 95 to 99% of that is albumin, but is usually a part of the protein that is done. It will also precipitate in the same fashion. So usually those methods are the ones which are used in the clinical practice. And in albumin, unless one is using a good method and you know the labs, otherwise albumin may not be providing you that good kind of. Okay, so proteinuria is something. What is it? And clinically, most of the time you are measuring proteinuria predominantly for the purposes of monitoring glomerular disease or progression of kidney disease by and large. The degree of proteinuria would reflect with what happens to albumin as such. And there are formula by which you can convert protein into albumin. Also, there are formula which can look at how much of, if you do a 24 hours urine protein and how much would be the albumin. Usually there are reasonably good formula on that also. Now, why have we started doing UPCR? Urinary spot urine protein creatinine ratios. Anji, why have we started doing urinary protein? Isn't it?
Convenience of the patient.
Fun?
Convenience of the patient.
Convenience. So for convenience, as we discussed that 24 hours urine collection is difficult. So there is, communication is a problem and then patients don't understand, they might miss. So they're difficult to do. They're very difficult to do because you are not able to collect these urines. You will miss many samples. Therefore, for convenience. And these are to be repeated so often for day-to-day practice. In every time a patient comes, you would want to know what is the degree of proteinuria. They also want to monitor it. So you will want to do it. So you do a spot urine protein fractionation. But is it reflective of 24 hours? Is it as good as 24 hours or no? Not as good. So what's the problem with spot urine protein creatinine ratio? But how is it that a spot urine sample gives you a picture which is similar to a 24 hours urine, isn't it? So a spot is based on what? Why is it that a spot urine will give you a value equivalent to a 24 hours? For example, you can divide them again, say albumin, normal albumin, the UACR of 30 will tell you it is normal albumin, 30 to 300 tells you it is moderately increased albuminuria, and more than 300 will tell you it is increased. A spot urine albumin creatinine ratio also gives you a similar kind. But how is it explained? How come? Anyone? Anyone? Right? You go similarly. Exam? What?
They are getting it at a creatinine ratio divided by.
No. Urine protein creatinine ratio or albumin creatinine ratio तो है ही है. But why would it become almost equivalent to 24 hours? Anyone?
At the same time, in the same sample, we are taking creatinine and albumin.
हाँ नहीं, but वो same value कैसे आ जाएगा?
Creatinine is excreted uniformly throughout the day.
That's not absolutely true. It's not excreted the.
Constant.
There is some variation, but anything else? How much creatinine does one excrete? Yeah, about a gram. So it's usually 20 to 25 milligram per kilogram body weight in males and 15 to 20 milligram per. So it's usually based on that we excrete 1 gram of creatinine, and when you divide it by 1, it will become equivalent. In 24 hours urine, we pass 1 gram of creatinine in 24 hours. So then you divide it by 1. So that's the reason why you get an equivalent of a 24 hours reflection on the spot urine protein. And that's the limitation of this test also. It's an assumption that, so which individuals will it be different?
Volume of urine.
Volume of urine to nahi hoga. That is what it cuts. Creatinine, irrespective whether you pass 1 liter of urine, or you pass 500 ml of urine, or you pass 3 liters of urine. It will be 1 gram still. Because you excreted not based on the volume of water that you have taken. Urine volume is dependent on the amount of water you have taken. But creatinine is dependent on the muscle mass. So what people will it be affected adversely? People who are not necessarily obese but muscular, extremely muscular people. Those who are beyond the normal values, or those who are malnourished, protein energy wasted people. And patients with kidney disease are frequently protein energy wasted. So that's where it would be. So the limitation of a spot urine protein creatinine ratio would be that if the person is in the extreme of weight, a muscular person and an extremely malnourished person, this assumption may not necessarily. And if the denominator is either high or low, so it will either underestimate the degree of proteinuria or it will overestimate. So in a person who is lean and thin, we think that it is, but his creatinine is going to be less actually. So we will overestimate it. And in an extremely muscular person, we will underestimate it because the creatinine will be in that person will be more, and we are assuming that the denominator is going to be high. So if you have a high denominator, the degree of UPCR value would be on the lower side. So you will underestimate the degree of. So that's the one of the limitations of it. And any other limitation, volume doesn't affect it. And that's the reason of doing a UPCR. See, 1 plus, 2 plus, 3 plus is like when you put 1 spoon. These are patients come in, तो मेरा urine तो पिछली बार तो 1 plus था, आपकी दवाई से खाया, अब ये 4 plus हो गया. अगली बार आता है साहब ये फिर कोई क्या हो रहा है, ये कुछ समझ नहीं आ रही मुझे रोज. So that's basically because you can vary it as per the 1 plus 2 plus is 1 teaspoon of sugar in a cup, add 50 ml of water, measure sugar 200 ml. Add 50 ml of more water, it becomes 100 ml. Add another 100 ml, that's 50 ml. Add another 200 ml, it becomes 25. So sugar is the same, but the amount of water. And creatinine eliminates that effect of water. In fact, people can cheat. If you drink large amounts of water on the day you're getting your urine examination done, your albumin 1 plus becomes 0 or negative. You drink large amounts of water. You want to show that you are very ill or your proteinuria is gone up, don't drink water, make it concentrate. Your urine will become 4 plus. So that's the effect of volume, and you want to know exactly what that urine protein is. That's why you need a urine protein creatinine ratio, but there are limitations. So you should know that where these limitations may affect your estimation of these. And then protein, as we talked about, during the daytime protein is more. So sometimes the spot urine protein if you do it in an early morning, many times if you read in the books, you say that early morning urine, then early morning urine may be predominantly 6 hours of sleep. So you may have, therefore many times books have also told you that you take the next morning when you are not the first one, because that may be not reflecting the true protein excretion. So you are somewhat up and then next morning. But I think in the clinic and in practice, you can always do it at any spot urine protein, but usually tend to do it at the same point of time next time, so that you tell them that if you do it at 10 o'clock, do it 10 o'clock sample, do a urine protein crack. Or whenever, if he is coming in the morning to your clinic, tell him to do it there and then, because many times they wait in the clinic to find out the report. So you could ask him to do it at the same time. So usually that's another variation which occurs in urine spot. So you must know the limitations of all these, and then you might be able to explain it sometimes to the people, the variations which might occur in these. Somebody has gained weight all of a sudden, and then you start looking at this. Happens especially in transplant patients. They were 64 kgs at the time, and they become 100 kgs in 1 year's time. And then all these things will change. So that's the reason why it needs to be said. But once you know these methods of quantification of urine protein, because that's important, and since we said that both proteinuria and albuminuria are independent risk factors for many of these bad outcomes, so you need to see that you use drugs by which you can reduce the degree. And is there anyone who tells me any evidence to show that reduction in proteinuria improves the outcomes? Any studies which have looked at decreasing proteinuria? So in many of these studies, what are the endpoints people have used as far as proteinuria is concerned? Either reaching less than 500 milligrams, isn't it? Those are the outcomes used. Less than 500, whether a person reaches a complete remission or not. A partial remission is 50%. Because you have linked these to the outcomes of the patient. Development of ESRD or doubling of serum creatinine, those were the other outcomes. These are surrogate markers for end-stage kidney disease. Some people have questioned these surrogate markers, but by and large, doubling of serum creatinine or rapid deterioration in kidney function, 40% reduction in GFR, these have all been used, and 50% reduction in proteinuria is also being used in lupus and many other studies. When you look at the outcomes of these studies, by interventions by which you reduce proteinuria, and even in chronic kidney disease, obviously reduction, diabetic kidney disease, renal, other studies. Okay, they didn't look at mortality to that, but cardiovascular mortality in HOPE, micro-HOPE studies were altered once albuminuria was decreased. And the drugs of choice for these is A's and ARBs, isn't it? But what prevents people from using A's and ARBs? Tell me one reason why you are not able to use A's and ARBs. What prevents you? Huh? First thing. Huh? Hypokalemia. Yes, hypokalemia. But more than hypokalemia is the fear of hypokalemia. The fear of hypokalemia is not. What's the highest incidence of hypokalemia in studies where A's and ARBs have been used in studies? What's been most of studies where people have looked at A's, ARBs and looked at the incidence of hypokalemia? What's been the highest incidence? And these are studies where potassium is monitored. Every visit potassium is monitored, isn't it? And they are using these drugs at optimal doses. And the optimal doses are the highest doses that you can use in these patients. So which is where these studies have been done. So you start usually with a small dose, say telmisartan, 40 milligrams, sometimes maybe even 20 milligrams. And then you go up, titrate it to 40, 40 to 80, 80, you go up also. But 80 would be a reasonable optimal dose for telmisartan. So you would want to use 80 milligrams of telmisartan, but many times you fear of hypokalemia doesn't allow you to go to that dose in many of these patients. And then you're worried that patient has already creatinine of 3 or 4 and you're saying that no, that patient, there is no need to use this because you feel there's no benefit of this. So you're not able to use it. But what's the incidence, highest incidence? 15%, 14%. Is any hypokalemia, and hypokalemia is defined as more than potassium, more than 5. In these, in 5.5, and more than 5.5 is in fact considered to be a severe hypokalemia. So usually, incidence of severe hypokalemia is less than 5%. And people where drugs have to be discontinued for fear of for severe hypokalemia is less than 1%. Most of these studies, all the studies, highest incidence 15%. So which tells you what? It tells you what? That you should be able to use these drugs at least in more than 85% of people. But how much do nephrologists use it? What's your guess? Tell me, how much do nephrologists use them in their practice? Anyone making a guess? What's the percentage of use of ACE or ARBs in a nephrologist practice? What will be your guess? In India? 5%. Nephrologists should be using it by 85% though. Use hona chahiye. What's your guess?
30%.
30%. I'll show you what I found. Look at this. That's my talk tomorrow in Goa. What I don't find in a nephrologist prescription. So I looked at 100 prescriptions because I get usually second and third referrals of nephrologists. Being senior, so obviously I get many patients who have already been seen by nephrologists. So during the last, I picked up this topic about 2 months back. So I looked at these prescriptions during the last 2 months. And I analyzed these prescriptions. And this is where I felt that people should be using ACE and ARBs, and many of these are chronic kidney disease patients, not active glomerulonephritis, not active. Glomerulonephritis may have been treated, but they've achieved a state of a chronic kidney disease and no active glomerular disease being treated. So diabetes mellitus causes were about 62% of these patients were diabetic kidney disease with hypertension. IgA nephropathy and glomerulonephritis, different causes, 13%. Autosomal dominant polycystic kidney disease, 2%, and unknown about 23%, where we didn't know what the cause was. Now, look at quantification of albuminuria, and we talked about albuminuria. This is why I thought that as nephrologist I need to talk to you about albuminuria, because this may not be emphasized to that extent that it is one of the most important markers of death, cardiovascular death, end-stage kidney disease, and progression of kidney disease, which is what you and I should be worried about. Every patient of mine should be worried. But look at nephrologists, it's not been measured. 21% quantification of albuminuria or proteinuria has occurred only in 21% of these. They have a urine routine examination, but they don't have a quantification. Use of ACE and ARBs, 17%. SGLT2 mostly started by endos, 24%. But if you look at the SGLT2 inhibitors, if you look at all the studies, where have they been used? Was the background treatment? Background treatment, patients who already been on optimal doses of ACE and ARBs. And 95% of these patients are on ACE and ARBs. So you should be using SGLT2 inhibitors second after you have used ACE and ARBs. Finerenone, third drug, non-steroidal mineralocorticoid receptor antagonist, 6% of patients. This is another drug which is used. Now you use, erythropoietin is used so commonly, but you would want to know every time when you give this injection whether your patient is iron depleter. It's no use flogging a dead horse if there is no iron or material by which you will make hemoglobin. So how will you expect the EPO or ESAs to work? Iron status done by only 22% of nephrologists. Vaccinations, 17%. We talk about preventing severe diseases and all those, 17%. We use nodosis as one of the commonest things, but we don't monitor bicarbonate levels. We just give it 500 milligram per day. We believe that it will do wonders, but without measuring, we don't know. Patients might become alkalotic or they may not be getting adequate dosages. So we just don't monitor serum bicarbonate levels, because KFT doesn't usually include it in this, unless you ask for serum bicarbonate levels. Assessment of nutrition, I show you the prescription at the end, keto analogs, QD4, Celezarin, some other drugs, I don't even know if these drugs are, but these are very frequently used by nephrologists, very, very frequently used by. Now, keto analogs are used in which kind of patients? Where would you use keto analogs? Where have it been being used in studies? Which patient has keto analogs being used? In chronic kidney disease? Anyone? MDRD study also used keto analogs. MDRD study, everyone who is going for exam should be knowing MDRD study. That's one of the largest studies on nutrition in patients with chronic kidney disease. So go with full facts about MDRD study, largest study on nutrition. They used a sub-arm where they used very low proteins, so it's used as a protein supplement for very low proteins, which is 0.25 to 0.45 grams per kilogram body weight. Most of the study they use 0.6 to 0.8 grams, so 0.6, 0.7 grams of protein in the usual protein restriction arm, and a regular protein in the non-protein restricted arm, which was about 1 gram per kilogram body weight. And the keto analogs, and even in another study where keto analogs were used, this was used only as a supplement for very low protein diets. Now, what's the prevalence of malnutrition in India? Overall, normal population, by nutritionists? Anyone? 40%. 40% of people in India are malnourished. CKD population, what's the prevalence of malnutrition? Very high. So 60 to 70% of them, mild to moderate. So, nutrition. Who at Medanta did nutritional? Did someone look at nutritional assessments and all? No, I don't. Was this a thesis for somebody? No, I don't remember. Okay. So, severe malnutrition also exists in about 10 to 15%, especially on dialysis. Severely. I don't know, many of you would have seen people, skinny people who were walking and they lost 20 kgs of weight while being, because they worried about creatinine. They stopped eating milk and dal, because many physicians and dietitians tell them to stop eating dal and milk, and if that is the all protein that exists in the Indian diet, vegetarian diet, there isn't much. Paneer is not taken on a regular basis by people, so dal and milk is the only good quality protein to some extent. Milk, not even dal, but चावल चपाती में तो 6-7 ग्राम प्रोटीन है भाई, जितना आदमी खाएगा. So there is severe malnutrition which occurs in patients with chronic kidney disease. So although these prescriptions are very commonly used, you find, but you don't find any किसी ने nutrition का कोई एक comment भी लिखा हो कि भाई this guy is nutritionally well preserved, this is important element in the outcomes of our patients, and diet becomes an important treatment modality for these. The patients are very keen asking for what diet they should be eating. They ask for it. This is the commonest question asked by patients. What should I eat? Because they feel that eating is something that will definitely change this disease. So it's important. But no mention about it. Even when you are using these supplements are used in, and in the MDRD study, they didn't show very low protein diet with supplementation, did not show any decrease in the progression of kidney disease or decrease in the endpoint of that study. So it had no effect as far as delaying the progression of kidney disease or slowing down the progression of kidney disease. And in fact, although they were not able to show it in that 3 years period in which this study was done, but when they followed up patients for a longer period of time, many of these patients in this subgroup of very low protein diets died of malnutrition. They had high mortality because they died of malnutrition. So you need to follow these patients for a longer period of time. So let me. This is, although this paper is 1983, this is a relationship of 24 hours urine protein and protein to creatinine ratio, a linear line, very good linear line as far as when you do a population study. In an individual patient, I told you that those variations which we talked about, protein excretion, creatinine being not standard, but in a population study, urine protein creatinine ratio and 24 hours urine has a very linear. But look at this. This paper was published in 1983, but UPCR started coming way. For 25 years, not even nephrologists understood that 24 hours urine could be replaced by a spot urine protein creatinine ratio. It took many years for us to understand that we could use this for a more reproducible. And this is that if you catch these patients at the stage of microalbuminuria, okay, in this study, you have on A, you have microalbuminuria, and on the y-axis is a decline in the GFR. Okay, you have, if you go, you have a decline in the GFR. So this is the control. This is the control. So microalbuminuria, no ACE or ARBs, the GFR goes down. Microalbuminuria with enalapril, the GFR remains. 1 year later, the GFR remains the same. So in this stage of microalbuminuria, if you are able to you get these patients in early stages and you use ACE and ARBs and optimize them to get them to a normal albumin level. You might be able to get them to a normal albumin level, and then you will be able to prevent a decline in the GFR. Macroalbuminuria, even when you use enalapril in them, you are not able to prevent the decline in the GFR in this patient. You can slow down the decline. You can see it is slower than the control arm, but you still will have some decline in the GFR. So it's very important to catch hold of these patients in the stage when you have moderately increased albuminuria, which is what microalbuminuria. This is a study which was done when we used to call moderately increased albuminuria as microalbuminuria. And this is what these many studies, HOPE, and various clinical IDMT, renal trials have shown that even after using optimal doses of ACE or ARBs, you still have a residual risk, which remains, by which the kidney disease progresses, and therefore you need, and this is true even in the non-diabetic population as well. So Ryan study was the non-diabetic population run by Ramosi. So there is still, after using ACE or ARBs, you can see that there is a residual risk. That's why SGLT2 inhibitors need to be added, and maybe finerenone also needs to be added in patients where you can use these drugs. Therefore, this is, I have deleted the, now look at this. I didn't even notice, this is the first time I read, I like CKD. I don't know what this drug is, I don't know yet. And then you have QD4, Celezarine, Renologue. So these are commonly used patients. You will get all these prescriptions very commonly in your hand, but they are not. So my plea to nephrologists is going to be that please make a checklist in your outpatient clinic. And I think it's important to have a checklist. Checklist should include that you need to do an albuminuria assessment by a quantitative method. Because this is a marker, biomarker for all the things that we talked about. And I think that's the reason why you need to do this. You should, blood pressure monitoring is extremely important. We didn't talk about it. If you were to ask me that what is one single adverse marker of progression of kidney disease, that's the degree of blood pressure control. And I think if there is one thing that people need to be worried about is how good the blood pressure control is. So I think one should, the best measurement for blood pressure control is by home. So train your patients to get a machine by which they can monitor, and try to convince them to bring a chart of their own blood pressures which they monitor at home when they come to the clinic. That's a better reflection of what's the blood pressure control than the office blood pressure which is existing. And there is enough data in the literature to show that home blood pressure is almost a surrogate marker for an ambulatory blood pressure monitoring. So home blood pressure is good, so that's what needs to be done. So do convince and try to. ACE and ARBs, whether you're given it or not, should be looked at. Every prescription. Is there that I can use ACE and ARBs? And then optimize. Don't consider, you start with usually a smaller dose and then optimize the dose. And continue to optimize that dose. There is no dose which is every dose to a personalized dose for that patient. And what are the things I would look at? Blood pressure and albuminuria. I need to look at, if I have used 5 milligram of enalapril or enalapril, the ones which we use commonly are either telmisartan or Cardase or other drugs. So ramipril. So if you use 5 milligrams and you feel that the blood pressure is low, I go to albuminuria is still not come down to lower levels. I will go to 10 milligrams. If the patient tolerates it, I will go to 15 milligrams. So keep on increasing it to optimize it. checking that your potassium doesn't go too high, your blood pressure is not too low, and you are able to get the albuminuria, proteinuria down. That's a marker. So you need to optimize that. And if you once you reach that dose, then go on to HGLT2 inhibitors if they allow, and then to if that is also tolerated, and then go to non-steroidal MRAs if you can. Monitor bicarbonate before you use soda bicarb therapy. It's been shown to be a treatment modality by which you can reduce progression of kidney disease. Acidosis is an important factor for that. So it's a modest factor, not the most important. The most important is blood pressure. And that's where we should do. And our aim, the first thing that I've seen many prescriptions of mine going to whenever nephrologist, they go, Bihar mein kisi doctor ke paas gaya, the first thing, what is the first thing he does? He goes कि मेरी थोड़ी सी creatinine बढ़ गई, तो वो कहता है अरे ये तो है एज डॉक्टर ने दिया हुआ, भूल गए, बूढ़े हो गए, वो एज इनहिबिटर creatinine 4-5 हो गई, तुम्हें अभी भी खिला रहे हो, तो हटा देता. He comes in end stage kidney disease. Back to you. So nephrologists find the easiest method, the low hanging fruit is remove A's and R's. So that seems to be. अरे भाई देखो तो सही, there may be volume depletion which may happen. You may stop it for some period of time if there is volume depletion involved. But bring it back. Anyone who's stop ACE study, what is the stop ACE study? पढ़ते नहीं हो आप लोग. एग्जाम गोइंग कितने लोग हैं? हाँ, ये 4 तो मुझे पता है यहाँ पे आप सभी एग्जाम गोइंग हैं. देखो इतने सारे हैं. But exam going look, huh? नहीं, stop ACE.
Intermittent use of ACE is more dangerous.
Stop ACE was a study which looked at whether stopping ACE in patients with advanced kidney disease, stage 4 kidney disease or stage 5 kidney disease before they go on dialysis, whether it has an impact on progression of kidney disease to need for dialysis and all that. And so it was a randomized trial. Advanced kidney disease, usually ACE and ARBs were sort of not being used by most people. So there has been a controversy whether should you use it, not use it, and all that. So Stop ACE wanted to look at it stage 4 kidney disease, stage 5 kidney disease before they go on dialysis. And they randomized these patients into 2 groups. And in one group they stopped ACE, and in the other group they continued ACE. So Stop ACE was that trial. And in the group which they continued, the need for dialysis or became lesser, and the mortality, all-cause mortality. So ACE and ARBs, as we talked about, are important for mortality because they decrease the mortality, cardiovascular mortality in these patients. So in another study, there was a slight increase in deterioration in kidney function, very not significant as such, but mortality was much lower. So these studies suggest that actually there is also a study which looked at acute kidney injury, which is where most of us would feel that we should stop ACE or ARBs because that might cause an acute deterioration in GFR and all that and all. So even in acute kidney injury, stopping ACE has been proven to be not that harmful actually. So you should not necessarily. But even if you do stop these drugs for acute conditions, worsening fever and acute sickness rules. So sick day rules need to be followed whenever you use SGLT2, ACE, ARBs and all that. When you get acutely sick or you are admitted in the hospital for surgery or some other thing, stop these drugs. But do not forget to restart these drugs again. So that's very, very important. So the other plea is that do use iron assessment before ESAs, vaccinations. So the checklist should include and avoid unnecessary drugs. And this patient, the prescription I showed you was from a nephrologist, and she went against this nephrologist to another nephrologist trying to seek तो बहुत दवाइयाँ हैं, ये कैसे कम होंगी? So pill burden is something which is extremely important. Our patients have to take 30 pills, 40 pills, and what do they take? Because they feel that keto analog, silazurine, these are kidney drugs. So they will stop blood pressure medicines because they don't feel blood pressure is as important. They will feel kidney drugs are important because that's what they were worried about. So they will continue to take drugs for which there is very little evidence, and they will continue to take. So it's very important that you get this right. So I thought that. So any questions? So I thought I'll talk about albuminuria because these are things which are not necessarily taught in this fashion. Anything else? Tell me. Any questions? कोई सवाल नहीं? Yeah.
So, should we use what urine PC ratio in oligouric patients? As the quantity of urine is not that
It may not give you a good sort of an estimate. Whenever, so when should you, let me go and answer your question in a different fashion. One that, which I think should be discussed also, I missed it, that when would you use 24 hours urine now that spot urine protein creatinine ratio? So I think in any patient that you see, I think you should first have a 24 hours urine before you make a diagnosis, and at the same time in the same urine do a spot urine protein creatinine ratio, because that gives you a correlation between 24 hours and the urine protein. And then for follow-up, but whenever there is a disparity which we talked about, then do a 24 hours urine, because 24 hours urine still remains the gold standard after you put it. In patients who are severely oliguria and all, it would be much better to do a 24 hours urine rather than a spot urine protein creatinine ratio. And even when this is based on a stable kidney function, so in acute kidney injury and all those, spot urine protein creatinine ratios will not be very, very effective because the creatinines are so rising, they're not stable. So it's all when the creatinines are stable in these patients, only then they will be effective. And the creatinines after the age is different people. Age also has an impact. About the age of 50 to 80 or 90 years, the muscle mass goes down and the urinary creatinine will also go down in such a situation. So with age, younger people will be more muscular as well as will have more creatinines in their urine than elderly people. So when you are looking at a 30-year-old young man and an 80-year-old man, the UPCRs, even though they may be having same degree of protein, UPCRs will be different in these two populations, and that's basically related to the amount of creatinine that is present in these patients. So this would be what one would be doing. So whenever you have dilemmas in UPCRs, do a 24 hours urine. That will be the best. Anyone else? Pediatric population, again, I think, but doing 24 hours is not very easy, and especially young children, and even otherwise. So collecting those. So UPCR is okay. It's been used, but very small children, I'm not so sure whether you may have to ask a pediatric nephrologist whether UPCR in them, very small children. But I think by and large, in 10 years and above, children whom you can convince to do it should be okay. UPCR should be okay. Anyone else? But yes, in children probably will be not as accurate as it would be in an adult. If there are no questions, then thank you very much.